pleasure to introduce our next speaker, Dr. Abdullah Alharbi. Is obtained his bachelor degree of medical science from the Qura University and graduated with MBBS from King Saud bin Abdul Aziz University for Health Science, Riyadh. Then he went to finish his fellowship in pathology, hematopathology, and blood transfusion from King Saud University. Dr. Harbi is currently the Director of Medical Laboratory, Medical Service Center from Imam University, as well as an Assistant Professor of Hematopathology and Transfusion Medicine, Pathology Department, College of Medicine, Imam Mohammed bin Abdul Saud Islamic University. Dr. Harbi will talk in the coming 25 minutes about MRD assessment tool in acute leukemia. Without further details, Dr. Harbi, mic is you.
Thank you, Dr. for this nice introduction. It's my pleasure, and I want to thank the organizing committee, SSBMT, for this invitation. So my topic is regarding the MRD assessment tool in the acute leukemia. The measurable residual disease describes that a disease detected only by laboratory technique with a more sensitive than morphological tool, like flow cytometry for detected the immunological MRD and PCR for molecular MRD. As it is found in the absence of the clinical signs and symptom is termed as a minimum. Prognosis is a variable for patient with the acute myeloid leukemia for pre-treatment characteristic like age, karyotype, mutation profile, response to treatment, chemosensitivity, achievement of complete remission. In a patient with less than 60 years, show the achieve of CR cure rate in 50%. Morphological assessment of response is not sufficient to predict the outcome. Risk of relapse inform a treatment strategy for consolidation or stem cell transplantation. The European Leukemia Net in 2017, they proposed the prognostic stratification to the favorable, intermediate, and adverse. With the favorable, if it is have a specific translocation or mutation in MBM1 without FLT-ITD, or with FLT-ITD with a low allelic burden, or by allelic mutation of CBVA. In adverse prognostic, if it is complex karyotype, monosomal karyotype with MBM1 wild type and FLT-ITD with the high allelic version, and if there is a cytogenetic abnormality not classified as a favorable and adverse, it will be intermediate. So what is the role of the MRD assessment? MRD is a highly prognostic in AML, and sometimes it supersedes a pre-treatment characteristic. It is not standardized across the field. So which optimal MRD assess we can use? What is the appropriate time? And should be MRD guided the treatment? And how we gonna report? Clinical implication of AML MRD, the European Leukemia Net indicate the complete remission without MRD as an official AML response criteria. Lack of standardization evidence-based recommendation in the US. Flow cytometry and NGS are complementary, and they use the apparent surface protein expression and leukemia-associated mutation. Method for MRD detection in the AML, we have the multi-parameter flow cytometry for leukemia-associated immunophenotype, or different from normal approach. The sensitivity is high. It's up to 10 to the power 5 for sensitivity for detection of the leukemic cells. The advantage for this method is widely applicable. It's up to 90% of the acute myeloid leukemia can be detected by this modality. Relatively quick, the result can be ended by the day, and the single result interpretable, high specific with the using defined leukemia immuno-associated phenotype. Can detect cell leukemic stem cell phenotype, can distinguish between live and dead cell, and provide the information about the whole sample cellularity. What is the cons for this modality? It's a little bit challenging and somewhat interpretation require expert pathologist. Sensitivity depend on the antibody panel use, limited, harmonized, and standardized across laboratory. Leukemia phenotype not necessarily stable over time. For example, the initial leukemia-associated immunophenotype may not identify a subclone leading to relapse. RT-PCR, the quantitative method, is also sensitive, which is reached to up to 10 to the power -5. It is widely applicable and run of any certificated laboratory with this capacity. The sensitivity is high and might be more than the flow cytometry. Well standardized, and the disadvantage for this method is result may take multiple days, expensive and time consuming, require high level of expert, and require setting of threshold limits. Interpretation often require a trend of result, and different mutation have a different biological consequence in AML. Molecular target applicable only in 50% of all AML cases. Next generation sequence also good sensitivity for detection of MRD. It has a relatively easy to perform, sensitive, and applicable to specific subgroup, while there is some limitation in standardization. Error rate lead to a low sensitivity of mutated subsequence. Mutated gene can be detected in healthy people without hematological abnormality. Persistence of some genetic abnormality in a patient in long-term remission, and there is a risk for contamination. FISH modality also has a little bit sensitivity up to 10 to the power 2. It's superior to the PCR-based assay for detection of a numerical cytogenetic abnormality, for example, in gain or loss of a whole chromosome, deletion, or duplication. But considerably less sensitive than PCR and the flow cytometry, not useful for the patient with the normal karyotype. Quality assurance probe are expensive. Technique is need a labor intense. A chromosome or a conventional karyotype, has a sensitivity of 5%, and more common in routine clinical practice, evaluated the dividing proportion of the cell, but is also costly and time consuming. The sensitivity is less than the FISH and not useful for the patient with the normal karyotype. Detection threshold of various MRD modality compared to the traditional clinical complete remission. We have the morphology, FISH, chimerism, and BCR and NGS with this sensitivity of detection of residual leukemic cell. However, the next generation, there is a clonal heterogeneity and evolution, and should be taken in consideration. So what is the approach of AML MRD by flow cytometry? It is unlike the B lymphoblastic leukemia MRD. It is not standardized approach. So we look for the leukemia-associated immunophenotype approach, and different from a normal approach. In leukemia-associated immunophenotype, look for apparent antigenic suppression, asynchronous antigen expression, variation in the intensity of antigen expression. The different from normal approach is usually used in the case of referred patient without no knowledge of original AML phenotype. And it is difficult to interpret. Sometimes the atypical antigen expression in regeneration must be considered. This is a panel for MRD assessment designed in National Guard, and they used the 8-color approach with the 4-tube, and they used a lot of antibody with the myelomonocytic marker and early stem cell marker to detect more appearance for when they deal for MRD. The strategy for the MRD study, after we take the bone marrow and the screening of antibody by multiple assay at presentation of the bone marrow sample with the identify of lineage and lineage association marker to be identified as acute myeloid leukemia or acute lymphoblastic leukemia. Then there is a secondary balance to identify leukemic-associated phenotype or different from a normal approach using 8-color of staining with the CD45 gating strategy. So if there's a negative in this patient, it says this not suitable to track MRD. But if we clearly specify the leukemia-associated antigen with the percentage of these blasts and the percentage of all the marker at the diagnosis, this can be used as during the follow-up and the tracking of MRD. And then you establish the MRD after every cycle of a treatment, correlate the percentage of MRD with the relapse and the refractory-free survivor and overall survival. In this case, you can see the gating strategy after they use the forward and high side scatter to tracking the blast, and with the positivity of CD45 and the CD33, and you can see after the cycles of chemotherapy, the decrease of the leukemic blast at the detected level of MRD is 0.03, and after 5 months of cycle, they again do an MRD and they detect less than 0.01%, but after 12 months after consolidation, you can see the minimal residual disease, it was positive, and that's case with the percentage 0.1%, and in the relapse after 17 months, the MRD with the same immunophenotypic has a 1.7%. So the prognostic impact of the acute myeloid leukemia MRD by flow cytometry and the remission post-induction. In this study, they identified that cases positive MRD more than 0.1 by flow cytometry, and they have stated the important prognostic marker that can help guide for treatment and decision. And you can see in the overall survival and disease-free survival difference between the negativity and positivity for MRD. Also, the other study, they see the relapse and refractory AML. Also, the MRD that's help for the treatment decision of 2 type of case, and also the relapse and refractory percentage of the MRD. There is some practical challenging in AML MRD detected by flow cytometry for the pathogenesis of AML due to the clonal complex neoplasm that drive the immunophenotypes, pre-leukemic cells, like in case of MDS, it might persist after a therapy, and there is some antigenic shift following the therapy. Also, for bone marrow regeneration can elicit the phenotype changing, particularly if there is a growth factor therapy. Sample adequacy can be a limited factor in case of ablation or suppression following therapy. There is some potential limitation for MRD detection using the immunophenotypic due to the heterogeneity of this marker, and you can see here in this diagram the aberrancy distinct from the diagnosis and the clonal identical or clonal evolution that arise from the diagnostic cell. Some common immunophenotypic aberrancy in the leukemic myeloid blasts. For example, we look for the increase and overexpression of some marker, decrease or loss of the other marker, or decrease and increase of the side scatter and 45. If there is an apparent lymphoid antigen present in the myeloid leukemic cell, like CD2, 5, CD7, CD19, and 56, asynchronous expression of mature myelomonocytic antigen like CD4, and 15, and 64. Some pitfall that is when you deal with the MRD by flow cytometry, you have to distinguish the early normal myeloid progenitor, and that is which is usually DIM34, bright 30, DIM38, bright 34, and when they get about the CD45, usually it is TIM to bright. Also, there is a DIM33 and 13, bright of 117, and HLDR bright, and 123, it is dim. There is also, you have to take in consideration, there is some normal expression of lymphoid antigen by myeloid progenitor, like CD20 is my expression in myeloid blast up to 1.8%, like in MDS case, and also CD7 expression in about 9% of MDS. The reporting of MRD in acute myeloid leukemia as a consensus document from the European Leukemia Network, Leukemia Net working group. They recommended that if it is below there is immunophenotypic detection of MRD with the true leukemia-associated anti-immunophenotype, but it's less than 0.1%. You have to look to the background, a prognosis. It might be there is a consensus with the residual leukemia. Also, you have to assess the viability of the cells and the quality of the sample that we provided to the lab. The percentage of the leukemia immunophenotype, it also should be mentioned, and the approach for AML MRD next generation sequence. You have to look for persistent and new mutation, clonal evolution, ML and clonal heterogeneity, mutation landscape often change post-therapy. Persistence of mutation do not equal residual AML. For example, like Dr. Haytham mentioned, in clonal hematopoietic, if that mutation, DMT3A and TIT2 and XXL1, often persistent, drive a mutation severe. Suitability for MRD detection marker, if you can see here in the leukemic, the drive mutation, for example, BML RARA, RONX1, CBB MYH11, it is sensitive and specific for tracking the MRD by molecular. While the some of the pre-leukemic marker have like DMT3 and TIT2, IDH1 and SF3B1. This is it can be detected post-therapy, so it is non-specific and not recommended to be used as an MRD marker. Also, post-onset driver mutation like FLT3-ITD and RAS, BTVN11 and KIT, this is might be changed after the therapy, so also is not suitable to tracking for the MRD. In this study, you can see the DAT mutation, which is about 50% of the patient that detected by the NGS at the diagnosis and after the induction of therapy. So this is it is not suitable for tracking of MRD. Relapse among those patients with the persistent DAT mutation has the study in this shown that is not DAT mutation had a high prognostic value with respect to the relapse, and there is no significant associated with the relapse rate than the not detected DAT mutation. But there is no significant correlation of a persistent DAT mutation with increased relapse risk. The RT-PCR for the NPM1 mutation, it is a good marker for detection and the give a probability for relapse and overall survival when they compare the after induction of therapy and after the completion of therapy. And you can see the difference between the MRD negative and MRD positive. So the monitoring during and after therapy of the NPM1 mutation allow to discrimination of the patient with the high and low risk of relapse. The PCR for the NPM1 mutation in the peripheral blood, it's better than bone marrow. And this study has shown that is the despite the bone marrow testing of NPM1 mutation does appear as more sensitive than testing via peripheral blood. However, the presence of the MRD in peripheral blood was highly informative among a patient in morphological complete remission. The use of and comparison in this study between the NGS and flow cytometry can give the prediction percentage of the relapse rate if you have a result from both modalities. So there's some recommendation by the European Leukemia Net for MRD testing. If you use flow cytometry, you have to use a full panel with these markers and monocytic tube. It can be added to increase the and explore all the appearance. The target classical of a lab approach and different from a normal approach in all apparency, and apply this is both in diagnosis and follow-up. Estimated the contamination from peripheral blood, especially if you use as a first pool from the bone marrow. Use the up to 1 million cells has to be acquired to as a good assessment for MRD. And for the molecular biology, there is analysis is different for you can use any anticoagulant. The mutation of the DANT mutation as well as the FLT-ITD, this is marker is not useful in the to assess and tracking of MRD. However, it may be useful when used in combination with the second marker. For BLL, this is a panel used with the 8 color and the 3 tube. And the pitfall for the BLL, it says it might be there is a highly percentage of the hematogone, which is mimic ALL. So this is hematogone. It is immature B cell found in infant and decrease with the age, increase and observed in the patient with the lymphoma, marrow regenerating state, and the immune cytopenia, acquired and loss of antigen resulting in the maturation speed, spread, hematogone panel that used like CD10, 19, 20, 34. There's some overexpression of the CD49 or underexpression of CD81, asynchronous of 123 with the 34 in ALL.
5 minutes.
Okay. And this is, you can see the hematogone, especially in the three type, the 3 stages have a decrease or increase the expression of the CD20 with the maturation and loss of the CD10. So in the hematogone, you have to see the approach of the hematogone. It is a low side scatter, and when you get about the 45 and 19, you can see also the type of and dim of the 38. This also percentage of all stages can be done, and you can see this different stage with the maturation, especially if CD19 with the CD10, and also you can use the different stage of maturation when you combine the CD10 with this one CD20 and give you like a question mark sign. Also, they have a TDT and the decrease the expression of the 34 and the increased expression of the CD20 with all increased maturation. Hematogone can be seen in the peripheral blood, especially the stage 1 and 2 can be detected in peripheral blood. Both pediatric and adult patients can have a circulating stage 1 and stage 2 of hematogone. When present in peripheral blood, early stage of hematogone are associated with the late stage hematogone, potentially helping to discriminate those early precursor from B lymphoblastic leukemia. My conclusion is, despite this substantial heterogeneity, MRD negativity has been reliable, shown to predict a risk of relapse and long-term outcome. And MRD detection has a strong clinical relevance in AML, and the new technological advance have increased in sensitivity and specificity. The ultimate goal of assessing MRD is to use this information to the appropriately guide decision regarding post-remission therapy. The development of a more sensitive MRD assay, including NGS, may all allow for even better risk stratification. Thank you.
Thank you, Dr. Abdullah, for this nice and comprehensive and more informative presentation. There is no question, but I have one question for you. You think how can assess MRD for malignant patients and treated patients in the minimal or limited resources in some area.
Yes, as we mentioned, that is in the diagnosis, you have to detect and assess the leukemia associated immunophenotype. In case of, and this is what it will help a lot for tracking the MRD by flow cytometry. The most important thing that is you have to use the same panel that we use in the diagnosis, and it has to be followed in the MRD. However, if you don't have the immunophenotypic marker at the diagnosis, so you can use the new strategy different from normal by the assessing the new appearance and also the pattern of the maturation and expression by flow cytometry.
Thank you, Dr. Abdullah. Thank you for all presenter and Dr. Mansour, Dr. Abdullah, Dr. Haytham for this informative presentation. In this session, I would like to thank also Dr. Ammar and organization committee for this informative events. We hope is will be done annually, and inshallah we'll stop for a break for Al-Asr prayer. We'll be back at 3:55 for second session. Thank you for all.